Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one size fits all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Good morning. This is Talking Therapy, and my name is Marvin Goldfried, having a interesting, hopefully, conversation with my long-term friend and colleague,
Alan Francis. Hi, Marvin.
Hi. Morning, Alan. I hope everything's okay on your end. I know you've moved into new quarters, and it's probably one of the high stressors you can experience.
Don't ask.
Yeah. But I think you always have to accept there will always be one carton that will never, ever get unpacked. And usually that's in the back of some closet.
More like 20.
Right. And then, 20 years later, it's very exciting when you open it up and find, oh, that's where that was put.
Marvin, I don't think we either of us have 20 years later. But
so listen, we agreed that we're going to have a series of podcasts for the next few times, starting with the birth and growth of behavior therapy in the U.S., then segueing into the introduction in the following podcast of cognition into behavior therapy. And then you're going to be talking about, in a third podcast,
I'll talk about the history of psychoanalytic treatments in the U.S.
In the U.S., that'll be great. And your personal experiences with it, hopefully.
Yeah, sure.
Yeah, good. Okay. Well, I think that I had, I don't know if I did mention in a previous podcast, when I was in graduate school, in addition to majoring in clinical, I had a minor in learning. So I took lots of courses in learning and read about learning theorists at the time who have since disappeared, but with the exception of Skinner, and found it kind of interesting. And was struggling to understand really what goes on in therapy when people change. And then I came across a book by Dollard and Miller, published in 1950, which I think is still available, Personality and Psychotherapy. And it was a translation of psychoanalytic theory and therapy in learning terms. And I found that very, very interesting because I could relate to that. I could tie suggestions of what to do in therapy to a body of knowledge.
Marvin, it's really interesting. That book had a big influence on me as well.
Really?
We were coming at it from opposite points of view. You were coming at it from the behavioral adding psychodynamic. I was coming to it from the psychodynamic adding behavioral.
Uh-huh. Oh, I'd like to hear that.
A paper by Feather and Rhodes around this a little bit later that did the same thing, so trying to integrate dynamic thinking with behavioral thinking.
Could you go into that at greater length when we talk about your experiences with psychoanalysis?
Sure.
Because I'd love to hear that. That'd be fascinating. So anyway, that was very, very interesting. And I still have that book somewhere earmarked with notes in the margins and underlining and everything else. But the real interesting thing, and I did mention this in a podcast, was when Wolpe's book came out in 1958 in the United States, where he said that psychotherapy can be considered as a learning process. And we know something about learning. We know something with extensive research on classical conditioning, where people develop emotional reactions. We know something on operant conditioning, where people learn to behave in certain ways. And his thesis basically, and he focused mostly on deconditioning anxiety, But it was very, very relevant. And when I spoke to my learning professor, he said it was a lot of crap, and he didn't think it would amount to anything. Well, then what happened, and it was fortuitous being in the right place in the right time, I learned that there was a new university that was going to be opening up on Long Island. It was being developed from the bottom up, and the idea was that the clinical program would center around research findings in learning. So this was like, Emerald City. And it was very, very exciting. I won't go into the details, but I did get the job. And the job consisted of, when I got there, of nothing, because there was nothing, literally nothing. There were a few hundred undergraduates and a few faculty. Harry Kalish was the chair. So we built a program, and I'm not going to go into the details of that. But what started to happen in the 1960s, so I got to Stony Brook in 64, and in the 60s, there was beginnings of research on how to reduce fears and phobias. And this was early work on snake phobias with Bandura, with Lang, with other people. And lo and behold, within a few sessions, you can get somebody who is afraid of snakes to being able to pet a snake or even put a non-poisonous snake around their neck. And this was set up as a paradigm for therapy. Can you imagine what the psychodynamic reaction was? I don't know if you know. Disdain, ridicule. People would say, well, I haven't had too many people who were snake phobic come to me. And then ridiculous arguments came out. And this was somebody who was practicing, I think, in New York City. So Bandura responded and said, well, out here in California, where we do a lot of hiking, there's lots of snakes. So it was a real petty fight back and forth. And basically, their thesis was it made no sense. It was a totally different way of looking at the therapy process. And they said, you're dealing with the symptoms. So you cure the symptoms, what are you going to get? You're going to get symptom substitution because you're not dealing with the cause. So behavior therapists, and they were all young, pretty much young behavior therapists at the time, said, well, let's look and see. This is an empirical question. Let's give a fear questionnaire to find out the participants' fears, and let's work on one of those fears and see if we reduce that, is there any increase in other fears? And what was found was there was no increase. In fact, there was a decrease.
Yeah, this whole idea of symptom substitution was a very foolish and retarding influence on psychodynamic practice, as well as not showing proper respect for what was happening in behavior therapy. What was not realized, I think, at the time, and some people may still not realize it, is that if you improve any one symptom, other symptoms get better. That you establish a virtuous cycle where previously there was a vicious cycle. And the idea that you unless you got to the root cause of everything, the problems would pop up somewhere else just turned out to be absolutely wrong. And helping people with symptoms was an excellent way of helping them get better from other symptoms and allowing them to deal with deeper problems.
Right. So it was interesting. And of course, there was an acceptance of the findings, which is nothing new. I mean, in the sociology and the history of science, you find that when something new is introduced, it's not immediately accepted. It often takes quite a bit of time, if it ever does get accepted. And I think this was and correct me if I'm wrong, in the early 60s, there was still a lot of drive theory analysts around, and not as much relational people as there are today?
I think the balance was shifting at that point, and more of the younger group of analysts who would less influenced by the European migration and more open to new ideas under the influence particularly of two people, Harry Stack Sullivan and Adolf Meyer. I think analysis began increasingly to take into account the interpersonal factors,
right?
And not just think about things that were inborn drives.
Yeah, and if there was a greater number of those individuals, they might have been less opposed, because the relational approach doesn't say you have to go back and resolve the unresolved conflicts. You can take a lot of it from the here and now and move forward. But in any event,
and just let me say one thing: it's not as if psychoanalysis was one unified hostile movement against behavior therapy. As you pointed out, a number of analysts were very interested in trying to combine and integrate the two techniques. And I was trained by people who were very open to that line of thinking. Yeah. That doesn't negate the fact that organized analysis was very rigid and rejecting.
So anyway, we had a battle, not unlike the battles that exist in politics nowadays, although, well, maybe just as vicious, because I do remember I was on a panel once where, and I forget who the analyst was, so I can't mention his name, but we were talking about reduction of anxiety. And he was presenting the analytic approach, I was presenting the behavioral approach. And then there was a point where I said, well, somebody comes in and they want their anxiety reduced, and we have methods of doing that. And then this person said, well, I don't work that way. If somebody comes in and is anxious and wants treatment, I'm not going to change the anxiety, because anxiety is part of life. And I said, well, but they're coming in asking for help, and you're saying you're going to be seeing them in therapy, and they're probably assuming that the therapy is going to make them less anxious. And he said, well, no, that's not necessarily the case. And I said, but if somebody comes in good faith and enters therapy, and they want to be less anxious, and you're saying, okay, I will see you in therapy, is that an ethical issue? That you're telling them, no, I'm not going to give you what you want?
Well, there I might have not agreed with you, Marvin. I think that it depends on the patient and the situation. So very often when I refer people, I want a symptom-oriented treatment that will deal with the anxiety, because that's the thing the patient wants. But there are times with certain patients who have different goals, where the anxiety might itself be a useful generator of information about.
And I in hindsight and with greater maturity, I see that now. But you got to remember, I think back then, I think I was in my late 20s. So you can see I had all this extensive life and clinical experience. Anyway, when I mentioned, might this be unethical, he started to get out of his seat, and he was coming toward me, and somebody had to restrain him. So this gives you a sense of what was going on in the 60s. We were, as behavior therapists, and we were mostly young behavior therapists, we were saying, you have to set goals for therapy. And then you work on the goals and use different methods. There was another...
Let me just say one thing, Marvin.
Yeah.
At the very same time, there was a movement towards brief psychodynamic therapy that had the exact same idea of setting goals, of having short-term treatment.
Interesting.
So that it's not, again, I don't want to make it sound like analysis was a homogeneous, hostile force against behavioral treatments and more flexible treatments. Within the umbrella of psychoanalysis, there were the most stubborn, impossible people in the world, and there were also people who were very flexible and not so different in their thinking and their approach from what you were doing.
Who were those people?
Well, the brief therapy movement in psychoanalysis started with Ferenczi and Ronk in the 1920s.
Who was that? I missed that.
Shandor Ferenczi and Ronk. And then in the 40s, Alexander and French suggested a focused short-term therapy.
Exactly, yeah.
And then in the 60s, Mallon in England and Davinloo in Canada and Sifnios in the United States all began to focus on short-term therapies. And again, the short-term therapies had a psychodynamic orientation, but they were much more behavioral than the long-term analysis that you're talking about, which was more hostile to what you were doing.
Well, correct me if I'm wrong. Didn't Freud do a lot of short-term therapy with people who came from other countries?
Yeah, Freud, because of the economics after World War I, the only people who had money to afford Freud were from Britain and from the US. And almost all of his treatments during the period after World War I, most of his treatments were in English, actually.
Yeah.
And many of them were quite brief.
But they came to Vienna
to be analyzed
for a limited amount of time, and that's why he saw them 6 times a week.
Well, he had other reasons for seeing them intensely. He did that even with the people from Vienna, but he was much more behavioral than his followers were. So Freud said something to the effect that you must have experience in life to really change. It's not going to all happen in the sessions. And he talked constantly to his patients. He was the exact opposite of the stereotype of analysts that became prevalent in the United States because his followers were much more rigid than he was.
Yeah. That's kind of interesting. Remember in a previous podcast, we spoke about Rogers and his demonstration with the patient Gloria, and he stepped out of role and described how he felt. And people said, but that is not a Rogerian approach where he says, well, because I'm Carl Rogers, I could do whatever I want. So I do think there's a humility and there's a recognition on the part of the people who start these schools that there's a certain amount of arbitrariness in the model. Anyway, you'll get your turn in 2 weeks. Let me finish my spiel, okay? So this was an interesting approach, and with the behavioral approach came other very interesting kinds of things, which is not written about, but which I've lectured to my graduate students. And that is because it was an extrapolation from research, clinicians started to think in terms of variables. And here's what I mean by that. The researcher will think in terms of variables. So the researcher will say, well, I want to find out something about the effect of anxiety on thinking, but anxiety is not a unified thing. There are degrees of anxiety. So I'm going to do a study that is going to grade anxiety from low to high. So if you think about this way as a clinician, then the whole notion is, well, the old notion, the patient is not ready to change. We have to wait until that person is ready. Well, maybe you can help that person get ready by gradually getting them accustomed to the kinds of situations they're having the problems with. So instead of the problem being a unified entity, it is a variable, which may be why many behavior therapists didn't kind of like the DSM, because it was categorical, not variable. Anyway, that was an interesting kind of thing. But there was still an even more interesting thing that happened in the 60s and 70s. And that was that people didn't recognize that behavior therapy was a major paradigm shift in therapy. Major in the sense of, how did the intervention develop? Did it develop within the consulting room, as analysis did, or did it develop from the laboratory? And behavior therapy suggested that maybe it should develop from the laboratory, not solely from the consulting room. Does that sound a little familiar to anything like translational research?
Well, it's interesting in the sense that although his conception of science was naive, Freud felt that the psychoanalytic situation was a laboratory. He divided psychoanalysis into a model of the mind, a treatment, and also research technique. Now, it's a very primitive research technique, but it had the same idea that at the beginning of any therapy, you shouldn't just be doing it. You should be thinking about how and why you're doing the things you're doing. The big difference was he didn't understand anything about statistics and rejected statistics.
Right.
So he was reliant completely on observational research and N of one situations, which are subject to enormous bias.
Yes, and that was the state of methodology back in the 1800s, and even the early 1900s. So certainly he can't be faulted by not saying you didn't base it on research, because there was no research that was there. So it doesn't mean that everything that he saw was bogus. It's just that it was confounded by the nature of the case and his ability to observe.
And the problem that actually statistics, the kind that we use today, developed in the late 19th, early 20th century. So that the tools weren't available when he started, and he never picked them up. He rejected them rather than realizing that statistical tools will be very valuable in understanding human nature.
Are you going to have enough to say in a few weeks about analysis? Because you seem to be peppering this.
So I'll shut up, Marvin.
That's okay. That's okay. So let me add still another thing to bolster my last point. In the book that Jerry Davison and I wrote in 1976, a updated edition here, somebody endorsed it in the back of the book and said, the book will be helpful not only to those who regard this cognitive behavior therapy as their primary orientation, but to anyone who wants to be a complete therapist. You know who said that?
Sounds familiar.
Alan Francis, Duke University Medical Center. So thank you for endorsing our book.
I wasn't endorsing just your book. I was endorsing the point of view that you've been espousing going back those 45 years, and that is that we have to be integrated to be complete.
You know, that's a whole other thing, and we'll get to some of that next week when we talk about introduction of cognition into behavior therapy in the US. But the point that I wanted to make was a reiteration of what behavior, of how many of us viewed behavior therapy at the time, not a new school of thought. And I think this has disappeared. People see this as a school of thought, and they see all the derivatives of behavior therapy as a school of thought. And I think it's short-sighted, because here's what we said, and I quote, "We believe behavior therapy is more appropriately construed as reflecting a general orientation to clinical work that aligns itself both philosophically and experimentally to the study of human behavior. The assumption basic to this particular orientation is that the problematic behaviors seen within the clinical setting can best be understood in light of those principles derived from a wide variety of psychological experimentation, and that these principles have implications for behavior change within the clinical setting." From the lab to the clinic. At the time that this was going on in the 50s, most of the research in the US was done on learning. A lot of it was on learning. There was very, very little research in other areas that gradually build up. Cognitive science was, I think was either in its infancy back in the 50s or non-existent at all as a field. There was some research in social psychology, and there was some research on social learning. That didn't come later until the late 60s. But I think to think of behavior therapy as the extrapolation from basic research, I think is very, very significant, because we have so much basic research now, research on other fields or in other areas, on cognition, emotion, not only just on behavior. on relationships, that all of this stuff is certainly potentially relevant.
How much were you influenced by Watson's work?
Not a lot.
Just for the audience, John Watson was a superstar in psychology who developed a behavioral clinical approach in the U.S., became president of the American Psychological Association at the age of 35, and then quit psychology. He was the chairman of Hopkins, the best department in the country, president of the association, quit psychology, went to Madison Avenue to become a public relations executive, and made a fortune.
Well, apparently his quitting was urged on by some unethical behavior that he engaged in at the time.
And so he was not a major influence.
He wasn't a major influence. And behavior therapy really had two wings. It had the classical conditioning wing, and then it had the Skinnerian reinforcement wing. And then gradually other stuff started coming in on social psychology and social influence. And that kind of broadened the view of, hey, this is not just learning and clinical work. This is extrapolation from basic research.
How much were you influenced by Skinner?
That's an interesting question. At the time, not a lot, because I think some of the radical Skinnerians were very much anti-cognition. And even back then, many of us felt, well, people are thinking, and this may be limiting. So I think from a point of view of what he wrote about, as far as his research, I think I felt it was too limited. However, I later realized that I was very much influenced by him methodologically, by his saying in 1950 that theories can be very, very dangerous, because if you have a theory and you want to prove your theory is good, and if you want to prove your theory is better than somebody else's theory, you'll do lots of research. But once that theory has fallen from grace, all of that research will be lost, and nobody will care about it. And he was right, because he was talking about the research to demonstrate that Hullian theory was better than Tolmanian theory, and that Tolmanian theory was better than Hullian theory. And you go to any graduate student now, and you say, who is Hull and who is Tolman? And they will say, I don't know. And then you say, have you heard of Skinner? And they'll say, of course. So Skinner said, beware of theory. And I add, beware of living theorists, because they're going to be generating stuff that may not be in the best interest of the growth of the field. But I'm looking at the clock, and I've got a patient in 10 minutes.
We'll carry on next week.
Okay, we'll continue next week. Stay safe, and good luck with your unpacking.
Thanks a lot. Bye-bye.
Okay, bye-bye.